in Cataract where we all sat around and came up with all these new ideas and what we want to do, and someone says, we'll check that, we'll do that. I think it's appropriate that today we take a moment and just reflect on the ethics of innovation. Let me ask a question of everyone out here. Who likes to innovate? Everybody, right? That's what we, in ophthalmology, we're big innovators. We love to do this stuff. It's cool. It's advancing the field. Everyone likes to have a new idea to do something new. So what is this thing, innovation? Well, innovation, if you look at the dictionary, is the introduction of something new. And we innovate in different settings. Sometimes we have to do something emergently, right? If an eye is having an explosive hemorrhage, we're going to do something right then and there. I mean, I'll use my shoelace if I have to, just to get that eye closed, right? Sometimes it's planned. I'm thinking I'm going to do this case this way, but it's fairly urgent. I don't really have the time to think about it. I just need to do the right thing. And other times it's purely elective, where there's no rush. We got all the time in the world. We're just going to try something new. And innovation comes in different sizes. And the size is proportional to risk. So if I want to say, I'm going to tie, instead of tying this knot 3-1-1, I'm going to tie it 3-2-1. Well, that's a tiny innovation, not a big deal, right? But if I say that I want to do this cataract in this kid with one eye closed, a hand tied behind my back, standing on one foot, that's an innovation that's a little bit more risky. And if I want to inject a steroid or something that hasn't been tried before, that's more risky. And we have different thresholds. Some of us will hear something at this meeting, we'll go home and we'll try it. Sometimes there's a peer-reviewed publication in the New England Journal. Sometimes it's just a throwaway journal. Sometimes it's a brilliant idea, right? You wake up in the middle of the night and say, I got it, I want to do this. And then we just try it. And innovation variations also come in the way they come to us. Sometimes they're totally new to medicine, first time someone's ever done it. Sometimes it's new to a particular situation, which in pediatrics is very interesting because there's many things that are first tried in the adult world, and they seem to work in the adult world, and then all of a sudden we start trying them in children, like IOLs. Sometimes it's tried and true, but it's new to you. It's the first time you've ever done. I was a resident when phacoemulsification came out, right? So we were all learning phacoemulsification, but we watched our attendings struggle as they had to relearn this new skill. Why do we innovate? Why do we do that? Well, the question we need to ask is, are we innovating for the patient, or are we innovating for ourselves because we like to do it, because it feels good to us? It's important that we always keep the patient in the foremost. And there have been many innovation disasters, and those innovation disasters are always discovered in retrospect. Closed loop anterior chamber IOLs. When I was a resident in training, we had to electively take those out of people's eyes before they got pseudophakic bullous keratopathy. Hydrogel episcleral implants in the early 2000s. CyPass taken off the market. Many, many things in medicine have been innovative and new and turned out to be bad. And that brings me to Scott's parabola. Scott's parabola is the waveform of innovation, where we start, we got a promising idea, right? And a couple people try it, say, oh, it's pretty good. I heard he's doing this. I'm going to try that. I'm going to inject this. I'm going to cut this. I'm going to do that. And then it rises, and then more and more people, and then there's a peer-reviewed publication that comes out. Everybody gets excited, and eventually it becomes the standard of care. That's how innovation happens. And you get to the top of the curve, and that's what everybody does. If you don't do it, like you're behind the times. But there's another half of this parabola. Doubt starts to creep in. There's a case report of something you want to miss. A few more case reports. Now there's a paper that shows it's not working well. And then we get to the point where we're saying, oh my gosh, can you believe we used to do that? And sometimes I wonder, what are we doing today that 10, 15, 50 years from now, we'll look back and we'll say, can you believe we used to do that? One of them will probably be IOLs. IOLs are going to be a thing of the past. We're going to look back and say, can you believe we used to put a piece of plastic in people's eyes? We'll probably just, ultrasound, disrupt it, put a little needle in, aspirate the lens, put in a new polymer that'll make a lens. Who knows? We don't know today what'll be crazy looking back in the future. And there's many episodes of what's called indication creep, where a drug comes out for an indication, and then drug companies usually, or doctors, push the limit, and you know what happens? Look, they get thrown in jail, they get major fines. You say, oh, this will never happen in ophthalmology. Well, what about Avastin? Like, you can't walk past a retina clinic without getting an injection. We use Avastin for everything. We heard the other day someone using Avastin in glaucoma surgery. People use Avastin in everything, right? Never with a trial. It's, let's try it for this, let's try it for this, let's try it for that. We push and we push and we push. That's called indication creep. And the authors of this article concluded that maybe it's okay for doctors, but not for companies. Like, companies go to jail, get fined hundreds of millions of dollars, but we're doing it all the time. Why is there no regulation on us? And we've seen that with laparoscopic gallbladder. There's never been a prospective study. There was never a prospective study for pediatric IOLs until the infant aphakia treatment trial, which showed that IOLs were not good in young babies. DSEC, femtolaser, medication, 80% of medications used in pediatrics have never been subjected to a trial. They just use them. Who are the people who innovate? Well, on the left side of the curve, we have the innovators, right? Those people, sometimes they're called the cowboys. They're out there, they're doing this and that. They're always got the newest, greatest thing. And then you go up the curve and there's people who say, I'm going to wait. I'm going to take my time. Maybe they're the old-fashioned people. They wait for more evidence before they innovate. And where you're going to innovate is a choice that you can make. You see, innovation is sexy, right? We love it. It sounds cool. When a patient comes in, what does a patient want? Do they want you, if you say, hey, look, I've got the tried and true, tested way, we've been doing it for 30 years, or I've got this new thing. It's really cool. It's a cutting edge. Patients want the latest, the sexiest, and hottest. And by the way, our trainees want that too. That's what they want to see. They don't want to see the old stuff. They want to see these new things. So we're like trapped into it. Do we need innovation? Absolutely, we need innovation. So if we need it, and there are some ethical challenges about how we get into this, an indication creep, what are we going to do? Well, innovation is and should be hard. It's not something that we should just be able to do like that without any thought. And there's a great book I recommend called Saving Sight. It's all about eye innovations. It talks about when Howard Ridley presented the first IOLs in humans, and Duke Elder walked out of the room saying, this is crazy putting IOLs in people. It talks about Louis Braille. It talks about all the innovations in ophthalmology and how hard it was to get there. So what gets in the way? Well, conflicts of interest. And we have to remember when we show those slides and say there's no conflict of interest at a conference, at this conference, they're all lies. Because every person has conflicts of interest. There's three kinds of conflicts of interest. There's academic conflicts. If you are doing something, if you're publishing, if you're presenting, that goes on your CV. You get promoted to assistant professor, associate professor, to full professor, right? Even me, I'm a full professor. I can't get promoted anymore. But when things go on, my boss likes to see that I'm doing academic work. When he hears I was in Pakistan giving a lecture, he likes it. It's good for the department, right? That's academic conflict. Number two, financial conflict, right? I'm not getting paid to stand up here, but I got a free hotel room in Lahore. That's kind of nice. I got some airfare. That's kind of nice. That's a financial conflict of interest. You don't have to be paid by a drug company. We all have financial conflicts of interest. And lastly is the personal conflict of interest. When I'm at home, in my house, no one will listen to me for 5 seconds. Here, I got 20 minutes where you're forced to listen to me. this is great. I feel good. I like it up here, right? I feel like a big shot, like I know what I'm saying, even though I may not. The point is that we have conflict of interest in everything we do. And when we innovate, we may be innovating for academic advancement, for financial interest. Maybe I'll get something named after me. Or maybe it's just for the ego of being the person who's got something new. And conflict of interest can get us into trouble because it's that duality of interest may cause us to cloud our judgment in favor of the innovation and ourselves instead of what's in favor of the patient. Disclosure, spelled wrong, unfortunately. Disclosure is important when you've got a conflict. But when you disclose to a patient, it doesn't remove the conflict. The conflict's still there. So what you have to do is you have to manage the conflict by giving the patient meaningful information. That means information they can understand. Now we say, oh, I don't want to tell the patient. The patient will be afraid. They won't want this. Wait a second. You're going to operate on the patient and give them informed consent? They can understand what a cataract operation is or a glaucoma operation? You're going to say they can't understand a conflict of interest? I think they can. Meaningful consent. The patient has to know that something is new. Something hasn't been tried before. Why you're doing it. How many times you're doing it. You have to have equipoise. That means if you're going to try something new, you have to really feel in your mind that you're doing it in the best heart of the patient without any other allegiance. That's hard to do. And beneficence, that you're doing the right thing for the patient. And lastly, you have the option of research. Now, the reason I'm giving this talk is I happen to be a bioethicist. I did my master's in bioethics, and I've been teaching bioethics for many years. And one thing that I've learned in teaching bioethics, there's no right or wrong answer in bioethics. There's no ethics police. Everybody has to do what's best for them. But when it comes to innovation, we have the research option. And the research option produces valid treatment, strong, effective, capable of producing the desired results. Do we go to a patient and say, Mrs. Jones, I have an operation I'd like to do. It's very innovative. Or do we say, I have a non-validated treatment I want to do? We would never say that. It sounds so bad. But in fact, that's what innovations are. They're not validated. If we want to validate an innovation, we do that through research. So I'd like to offer you something that's been research proven is different than an innovation. What is research? Research is designed to answer a question. It uses a scientific method. Why? So that we know there's no bias, that the observed result is not due to chance. It takes out the conflict. It gives us a scientific way of telling, yes, this is better, no, it's not. That's why yesterday I was talking about the registry, for example, for pediatric glaucoma as a way to test our innovations, to test our theories. And it's designed to identify problems before they occur through piloting studies and monitoring. If you do an innovative, everybody's done this, right? You do an innovative treatment, and after 10 cases, you write yourself, no one died, no one went blind, aren't I good? You publish a paper. That's not proven research. Maybe the person who's going to go blind is going to go be the 11th person. Research prevents you from getting in that situation. So it's tempting to just innovate. We like to do it. It's fun. Let's just go do it. And research is hard. And it takes time and sometimes money. But research protects you and protects the patient. And it's getting harder in this day and age. Technology is advancing. We've got gene therapy, the ultimate innovation I'll talk about tomorrow, stem cell, and now we have AI. I mean, we're just pushing the barrier, pushing the barrier, pushing the barrier. Somewhere we have to put the brakes on and say, hey, am I doing the right thing? And research can help us answer that question. So if you want to innovate, examine your reasons. Make sure you're making life better for the patient, not just for you. If you want to innovate, be honest. Be honest with yourself and with the patient. And if you want to innovate, do research. Research is a way to get into new things in medicine quicker to protect yourself and protect your patients. I'm going to close with this quote from William Feldman, who's now deceased. Over the centuries, medical doctors and other healers have tried a variety of treatments in a noble effort to help their patients. More often than not, the treatments were ineffective and sometimes harmful. Let us hope that physicians and surgeons will continue to rely less on trial and error and more on sound clinical trials. Thank you.
Thank you, Dr. Levine. Excellent message. Innovation is ethical only when it is supported by research. Sir, I would request you to take your place as chair of the session. Dr. Levine, please come forward. Let's formally begin our debate session. We have different topics and speakers will speak for and against these questions. Our first question is astigmatism in preschool children, immediate correction versus wait and watch approach. I will be speaking for the topic. Dr. Amna will be speaking against the topic. So let's begin. So astigmatism in preschool children, immediate correction approach versus wait and watch approach. Should refractive correction be initiated in younger children, or can it wait until visual demands increase? I will go with the immediate correction. Why? Because I do not want my patients to see the world like this. Reason number one, there is risk of meridional amblyopia. Results of several researchers have shown meridional amblyopia among children with simple compound myopic or mixed astigmatism, evidenced by reduced best-corrected visual acuity in measures of grating acuity, vernier acuity, contrast sensitivity, recognition acuity, and stereoacuity. The critical period for development of meridional amblyopia begins after infancy, and an early optical correction may prevent or eliminate the development of meridional amblyopia. The next reason why I would go with immediate correction is that if delayed, there is negative impact on early childhood development. Studies reveal that toddlers with uncorrected astigmatism perform poorly on Bayley scales of infant and toddler development, edition 3. Children with moderate to high astigmatism had significantly poorer mean scores on the cognitive and language subscale compared to children with no or low refractive error. Number 3, there is delay in early academic readiness. Presence of moderate to high astigmatism, that is more than 2 diopters, is negatively associated with multiple domains of academic readiness. It significantly lowers mean scores on personal and social development, language and literacy, physical development, and fine motor domains. My message would be treat the whole of a patient and not just the eyes. Don't just treat the vision, and prepare the child in terms of communication and language for the world. Immediate correction is better than to just wait and watch when it comes to preschoolers. These are my references. I thank you all, and I would like to invite Dr. Amna. She will speak against the question.
Thank you, Dr. Fiza. Well, when it comes to correcting a refractive error in a toddler or preschool children, I would say the wait and watch is a better strategy. So why? Because the period of early childhood in a preschool age, it's a period of dramatic anatomical and physiological changes. These some of the anatomical changes are change in the axial length. The axial length changes about 1.8 millimeter. It increases by 1.8 millimeter in first 6 months and by 1 millimeter in the next 6 months, which is dramatic change. Again, the corneal diameter, that is about 9.5 to 10.5 millimeter at the time of birth, and it changes to 12 millimeter. And the corneal steepness decreases. The cornea becomes flatter as the child grows. So the dioptic reading, the keratometric value of a child is 52 diopters at the time of birth, and then by the age of 6 months, it's 46 diopters, and then by the age of 1 year, it is 44 to 42 diopters, which is quite a change. Similarly, the power of the pediatric lens changes from 35 diopter to 23 diopters by the age of 2 years. So all these anatomical changes, they are bringing a physiological change. They are driving the eye towards the emetropization. These anatomical changes are meant to make an eye emetropic. So the process of these change in the refractive error of the anterior segment, increasing the axial length, and flattening of the cornea, these are the all changes that is moving the eye or driving the eye towards the emetropia. And thus it's causing the reduction in the astigmatism and hyperopia. So, and all this change is achieved by negative feedback mechanism. So, if you are fully correcting a child for the refractive error, you are actually stopping that stimulus that is required for the emetropization. So that would can lead to a permanent refractive error. And the rate of emetropization is proportional to the refractive error. So greater the refractive error, greater are the changes, and the child will proceed towards eventually towards the emetropia. Emetropization, it causes a loss of refractive error spherical equivalent, about half of it in the first year of life. Approximately 1/3 by the age of 9 months to 21 months. 2/3 of astigmatism is lost about at the age of 9 months to 21 months. So also need to consider the visual demand of the child. The children are not visually high demanding. छोटे बच्चे हैं, उनकी छोटी दुनिया होती है. We know there's no need to make a child 6x6. So they are low, the visual demands is quite low. And the studies also supported that 30% to 50% of the infants have a significant astigmatism that declines in the first few years of life. In 2004, a Dobson colleague, they found that there is no evidence of meridional amblyopia in 6 months to up to 3 years of child with astigmatism of 2 diopter or more. So I would say, so before, at the time of prescribing the glasses to a child, please consider these questions. Is this refractive error normal for that age? Will this refractive error emetropize? Will this level of refractive error will cause a visual disturbance to the child? Will prescribing these glasses will interfere with the process of physiological emetropization? At the end, I would say 25% of children are overprescribed. Thank you.
I would like to take the opinion of the House. Those in favor of early correction or immediate correction, please raise your hands. And those who are not in favor. So that is almost 50-50. Now we would like our experts to comment. What would you say?
I think that the best arbiter is the child. Children will only wear glasses if they improve their quality of life. And we all know that in the United States, it costs like $300 for a pair of glasses for astigmatism. And if you give a 2-year-old Plano plus 125 at Axis 90, that's a waste of money. They'll never wear it. They'll never wear plus 250 at 90. They'll never wear it. So I think that we have to be practical. There were excellent arguments for both sides presented. Thank you very much. But in the end, it's the child who's going to make the decision. And if the child's not going to wear them, I wouldn't prescribe them.
Thank you, Alex. My point of view is that the spectacles, they take the childhood, which is the golden period of any human being, takes it away. So it's a big barrier to the golden childhood memories, and it definitely restricts the quality of life of a child. So until and unless it is absolutely indicated, glasses must not be prescribed.
Thank you, sir. Yes, sir.
Yes, I agree with Dr. Ashalpal that, and also Levin, that we must be prescribing glasses only when it is really required in children, because they usually don't wear it, number one. Number two, that they wear it not very nicely. Usually they either look over or look under the glasses. So there is no point of giving the glasses to the children until unless really it is required.
There are guidelines as well. Like in the most easy decision making point will be and you are sure of that. Still, the child is not wearing glasses. It means he does not need it. He is not being benefited by the glasses. So there's no need. If anyone is being benefited and the child, he knows very well, he's a very smart creature. He knows that I'm seeing better. I'm seeing word better. The picture one, I think you showed that picture. If he's seeing a blurry word, he will put the glasses on. But if he's not seeing the word blurry,
Exactly.
he will not.
Yes.
I'd just like to offer one case report myself. I have 2.5 diopters of astigmatism, wear contact lenses. I didn't wear my glasses until I needed them to see the blackboard. You know, until you get to that point. Before that, as was shown very nicely, a child doesn't need to see 20/20. At a grade 1, the normal. So, you don't want to wear it.
So we come to the conclusion that wait and watch approach would be better. So just want to revise the rules. Your first bell will be rung at 3 minutes. That is your cue to start winding up your debate, and will be followed by a 1-minute discussion by the House and the expert. Our next debate is refractive surgery in pediatric populations, exceptional cases versus standard practice. We have Dr. Ashalpal who will be speaking for, and we have Dr. Zubaida Singh who will be speaking against.
Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, Assalamu alaikum. Thank you, Alex, for your very enlightening, informative, innovative, and hot lecture. Thank you so much. So my topic of debate, I want to make one thing clear that the theme of this debate is to present two school of thoughts. The school of thought I might be presenting might not be my personal choice, but I'm here just to present that so that the school of thoughts, both school of thoughts, may be properly highlighted. So my topic is refractive surgery in kids in exceptional cases. Okay. My first exceptional case scenario is anisometropia leading to severe amblyopia. So anisometropia is a condition you all know where there's a significant difference in refractive power between the two eyes, leading to an imbalance in visual input. In severe cases, this can cause amblyopia, a dreadful condition, lazy eye, where the brain suppresses the input from the weaker eye to avoid confusion. Standard treatments such as glasses or contact lenses are often effective, but may fail in extreme and exceptional cases. So here's an example to highlight why refractive surgery can be life-changing. One of my patient, Ahmed, an 8-year-old boy with extreme anisomyopia, a significant refractive difference between his eyes. Despite using glasses, Ahmed struggled with poor compliance due to the drastic image size disparity, which is anisoconia. His eye in the affected eye deteriorated rapidly, leading to functional blindness in one eye. Post-refractive surgery, Ahmed not only gained useful vision in his weaker eye, but also restored his binocular vision, enabling him to see a word he could never fully grasp before. Without this intervention, Ahmed's visual development would have been permanently compromised. The second exceptional scenario would be trauma and functional improvement. Eye trauma in children can lead to serious complications such as irregular corneas, which are often resistant to traditional corrective methods like glasses or contact lenses. In such cases, refractive surgery becomes an essential tool for restoring vision and improving quality of life. Here's an example. My one patient, Sarah, a 10 years old girl, she experienced a roadside accident with trauma to right eye that left her with irregular cornea. Her condition made it impossible to fit contact lenses due to the irregular surface, and the glasses could not correct her vision effectively. PRK surgery was performed as a last resort and successfully corrected her vision. After surgery, Sarah regained functional vision, allowing her to excel in school and particularly participate fully in sports and other activities. The third exceptional scenario could be non-compliant pediatric patients. We have talked about trauma. So the third scenario could be non-compliant pediatric patients. Children with sensory processing disorders or neurobehavioral issues like autistic kids, mentally challenged, often reject glasses or contact lenses due to discomfort or sensory aversion. These children may face developmental delays, difficulty in school. Solution is refractive surgery can provide the necessary correction, preventing amblyopia and allowing these children to develop proper vision. This is the last exceptional case, social and psychological benefits. By addressing the root of bullying, these kids, the kids who are wearing thick glasses, they are a victim to the bullying, and the root cause of bullying, if the refractive surgery is done, that can improve vision. It can help children rebuild confidence and allows them to integrate socially and thrive emotionally. The other two schools of thoughts may be, number one, make refractive surgery a standard practice. The risks are surgery on developing eyes can harm the immature visual system and long-term outcomes are unpredictable. Criticism over this approach is overuse in non-critical cases. Non-critical cases can lead to unnecessary complications. And the last point is that the other school of thought, still another, the third school of thought, never perform refractive surgery on kids. The risks are denying surgery in even exceptional cases can lead to permanent blindness, and ignoring extraordinary cases leaves children without hope for functional vision. Take home message is refractive surgery should remain an exceptional practice reserved only for critical, carefully selected cases where standard treatment fails. Exceptional cases deserve exceptional solution. Thank you.
Thank you, Dr. Ashal. Dr. Zubaida Singh will go with refractive surgery in standard cases.
Thank you so much, Dr. Fisa, and thank you so much, Chair and the co-chair and everyone here, and thank you for inviting me here. I'm sorry I didn't bring the PowerPoint because I was added at the last moment because Dr. Marian Aziz was not here. So I'll be presenting my against the standard practice arguments. I'm very thankful for Dr. Paul, and I totally agree for exceptional cases, but we cannot do refractive surgery in standard as a standard practice in children because children are in growing age. So they have this ocular growth with the passage of time that is leading to increased exilin and change in the corneal curvature that leads to unpredictable results in the future. So what is the use of refractive surgery in children if we're going to repeat it in few years time, or if it's not going to be useful in few years time? So that is the most important argument. Except for exceptional cases, we cannot do it as a standard practice. Secondly, younger corneas, there have been studies that show the younger corneas are biomechanically weaker than the corneas of adults. That puts the children at risk of most post-refractive complications as compared to adults. That can lead to ataxia and all the other complications that can occur. Third, there is lack of safety audit. There is lack of long-term safety data on refractive surgery in children. So it's like we're doing something, it would be innovation, but again, is it legal? Is it ethical? So we really need to ask that question from ourselves. Then there are ethical and legal considerations in which, because the child is not able to consent, and we are getting the consent from the parents who are putting the judgment on us. So we are the people who need to give them correct information for the future, for their children's future as well. And then there are a few other things like the child wouldn't be cooperative about corneal topography or refraction. So that is again going to give us unpredictable results. So these are my arguments against refractive surgery as a standard practice. I thank you so much.
Thank you, Dr. Zubaydah. So now I would like to take the poll from the House. What would you do? You will perform refractive procedures as for the exceptional cases. Those who would go with the exceptional cases, and those who will use it as standard practice.
Thank you for giving me. Thank you for giving me the opportunity. I practiced ophthalmology for 42 years, and I'm still practicing, though retired from the government job. Have seen all the ups and downs which all of you are seeing. Newborns, young children brought, those particularly with congenital cataracts, needing surgery, and we used to debate a lot. If we don't surgery, they are blind, then amblyoptic. If we do surgery, they can't see much because of high refractive error. So debates used to be, what is the fun in operating? That was the era when we were not doing intraocular lens implant in children. I'm talking of 98. One of my class fellows' nephew had bilateral congenital cataract. This was the second nephew, the first one had as well. And question was whether he would wear glasses or not at that age. And obviously I was skeptical like everybody else that, oh well, at this age he would not. But I did refraction on him and found out whatever was the needed hypermetropic correction. And I said, all right, take it, put it on his nose, let's see if he likes it. To my surprise, when he visited me after a month or so, he said, the child likes glasses. I said, did he say so? He said, no. When he wakes up in the morning, he starts crying. Mother feeds him, he is still crying. Unless we give him his fake glasses, then he stops crying. So that we have experimented it a number of times, and that is the outcome. So that is my experience, that when we say the child is not going to wear glasses, yes, may not, but they do want to see clear. So anything that helps them to see clear, they would ultimately like it and use it. May not be the whole day, maybe part of the time, but whatever time they are using, they are seeing better and their vision is developing. So my point is, if somebody is having a high refractive error, child, baby, he should be given correction. Waiting, okay, it's going to make difference. As Aguilagri explained, there are going to be changes. But who is stopping it? Change glasses every 3 months. Most of the time children break their glasses every month anyway. So you have to do the refraction, give them new pair of glasses, and my advice to the parents is, don't buy steel glass frame glasses for these, buy plastic ones, and buy the cheapest glass, because they are going to break it anyway and it's going to change anyway. So don't spend too much money on that. And that was actually the time when I started thinking of putting intraocular lens in these children, because they are not going to benefit from it. So question was, at what age we should start? Went through the literature, And there was a lady called Ada Mann from Australia who had worked a lot on anthropology as well as human comparison. And she had documented it, that the anterior segment of human eye is nearly fully developed by the age of 3 months. Rather, 2.5 years, she wrote. 2.5 years, she wrote, it is fully developed. So, learning that one, I said, okay, if we put another 6 months as a grace period and take 3 years child and put intraocular lens into their eyes, let's see what happens. Okay, obviously, some people have already done it. I was not the first one. So I did cases, had a lot of complications, faced them, but found out that where the media was clear, because there was a 90% PCO, which was helped by my colleague who used to do vitrectomy surgery. So he started doing, I would do the cataract, and he would come round and do the posterior vitrectomy at the same time. The results were good. So we say children need good vision.
Thank you so much,
If they are
sir.
going to develop.
Thank you so much for
Contact
your
lenses,
opinion.
sorry if I can complete
Yes,
it.
sir.
Contact lenses is another option. We tried it, and having worked at Woolford's Hospital, I had the data from there that a child needs about 22 contact lenses per year, and all need to be put under general anesthesia. So that was a big cost and a big risk, but the benefit of vision corrected by contact lens was much, much better. So we could not afford it here. That's my experience I wanted to share with you. Thank you.
Thank you so much, Professor Salim, for sharing your experience. Actually, we have a couple of debates lined up and we're short of time. We can have a question and answer session and opinions. At the end of the session, I would like to complete the debates. First, our next debate is on contact lenses in pediatric high refractive error, whether it is a safe choice or an unnecessary risk. We have Dr. Asma Mushtaq. She will be going for the topic.
Thank you so much, Dr. Fiza. Professor Salim Saab has already made my job very simple. He's already talked about it, that the contact lenses, actually the topic assigned to me was the aphakic contact lenses, basically post-operative aphakic contact lenses. So the answer is pretty simple, but we'll just discuss the reasons why the contact lenses make a better choice as compared to the glasses while we are dealing with the cases of post-operative aphakia, or that is actually the high refractive error we actually deal with. So first, the most important argument is that the contact lenses, they provide a better image size as compared to the spectacles. With the glasses, we have 20 to 30% increase in the size of the actual image. So this image size is very important because we are dealing with the kids who is actually in the developing phase of his vision. The image size which he is going to see is important for his visual development, and also the image disparity. If there is an image disparity between the two eyes, if you're dealing with the eyes in which we are putting glasses in one eye only, then the image disparity between the two eyes will actually impair his visual development, which is most important for his times to come. So the image size and the depth perception is an important aspect while considering the image quality which is provided with the contact lenses. So the improved optics, we can see, want my baby to see a smiling baby like that on the left side and not the one on the right side. And also there's decreased chromatic and spherical aberrations. Contact lenses provides a better field of view as compared to the spectacles, because the contact lens covers the whole of the cornea, so the child has a wider field of view as compared to the restricted field of view which is provided with the glasses. Similarly, the image disparity and the depth perception which is reduced with the spectacles leads to an isoconia, which is not good, and the child sometimes feels diplopia, and the overlapping images causes confusion, and that impairs not only his quality of life at that moment in time, but also his visual development, which is very important, especially in the early years of his life. And contact lenses are also flexible, they can be changed easily. Yes, I agree that it needs a little bit of parental counseling and education, but the parents I've usually seen are very much committed to the better image on the or the better quality of their child in the times to come. So they're ready to sacrifice all they can to make the child see better in his upcoming life. And the most important thing is that the glasses are a social stigma. No matter how much we educate, no matter whatever we do, the kids, they do face bullying these days, and it's being projected that it's reduced, but I don't think. In fact, the tools of bullying has advanced so much, and the things have advanced that it reduces the self-confidence of the children who are wearing glasses. It reduces their world, actually. Yes, they see do better, but wearing a contact lens, if we have a safe choice, so replacing a spectacle with a contact lens would make the child more confident in his daily life. And they are easy doing the sports activities, because I've seen kids, they say that we don't wear glasses when we go out to play the cricket or the football because they're not comfortable wearing the spectacles. So the contact lenses make a safer choice in those cases, and the child can be more outgoing and do better in sports. So keeping all these points in view, better optics, wider field of vision, and aesthetics, and the flexibility definitely make contact lenses a better choice as compared to the spectacles when we are dealing with cases of high refractive errors. Thank you. That's all I have to say.
Thank you, Dr. Asma. I would like to invite Dr. Sarfaraz Hussain, and he will be going against the contact lenses.
Okay, thank you very much. I'm talking about that we should not prescribe contact lenses to the children, as Professor Salim Saab already commented on it. Now, how many of you are practicing contact lenses prescribing in the children? How many of you? Can anybody rise? It's only one who is practicing. It means that is not practicable, because other surgeries which are even difficult than using contact lenses, you are doing it all. So you're doing cataract surgery, you're doing glaucoma surgery, you're doing other surgeries as well, but you are not putting the contact lenses in children. That means that is not a viable option for the children. Okay? So I think that should be all we should talking about. That there's no need for you can use it, but in the children, in exceptional cases, not in the other children. So now there are other reasons that why we are doing it. Because of the complications which are associated with the contact lenses. I sent it to here from the IT room, but it didn't reach here. But there are a lot of risks than the benefits using contact lenses. Now, the child has a very small palpebral fissure. So putting a contact lens in a very small palpebral fissure patient is nothing better. It is only impossible to put it in. Then they squeeze a lot. You have to put the contact lenses into these eyes who are already squeezing. Then there are other complications. You have to remove it and then put it again. So this is also very difficult in children. So I think I have done all, because everybody knows that it's not practicable in the children to put a contact lens, and it is associated with so many complications like corneal abrasions, corneal ulcers, and it is very difficult to treat these children who have got the corneal abrasions, because you even don't know what is happening. The child is not opening the eye. You have to take the child always to the operation theater or to the couch, open it with the speculums, and then you have to examine with the handheld slit lamp and everything. So each time you have to do it. So I think you can give the children contact lenses in a later age group who can handle it. The other, they play with the dust, they play with the sand, and you cannot restrict these children. They always, crawling over the floor. So all these things, there is a lot of risk of refraction and also maintaining it and monitoring it and everything. So I think this is not a good option for the children putting contact lenses. Okay, thank you very much.
Thank you very much, Dr. Sarfraz. I would like to take poll from the House. Those in favor of contact lenses for high refractive errors, please raise your hand. That is, I think, 20% of the House. I would like to take opinion from the experts. So you are already practicing it. Would you share your experience?
Once again, I think the child is the arbiter. If a child's wearing glasses, well, he doesn't need a contact lens. Unless the refractive error is so high that we'll see the optical benefits of a contact lens, like in aphakia or in high myopia. But having said that, because we know the vision's better with contacts versus glasses. Having said that, contact lenses are expensive. Not every parent can do it. You need to have the support team to deliver and get the contact lenses and make them available. So the scenario has to be right. An isometropia, where one eye's a high myope and the other one's not. The kid's not going to wear their glasses because they're going to see with their good eye. Put the contact lens in, it can help. So I think that it depends on the child, the availability, the expense, the compliance, so on and so forth. But when you get to the really high refractive errors, you get better vision with contact lenses. I think the more controversial question is, what about cosmetic contact lenses? -2. And my thought on that has always been, I asked the parent, does your child clean the room without being asked? And if the child is not doing that, they're probably not a good contact lens candidate. The child has to be responsible to decrease the risk, just like I'm wearing contacts and many of you are wearing contacts. You have to take care of them, wash your hands, so on and so forth. So before I put that in the hands of a child for cosmetic reasons, that I'm much less ready to do unless the kid is really mature. But high refractive error, I'll use them.
Thank you. I think it all depends in which part of the globe you are working.
Exactly.
If you are practicing ophthalmology in our part of the world, obviously practicality comes first. There is no question about, as Dr. Asma has rightfully mentioned, that there is no question the quality of life is definitely better with contact lenses. But in Pakistan, in a country like Pakistan, practicality always comes first. So considering cost and considering how the lenses are put in, how the parents are, they're taught for that all procedure, and many times they're lost. In a dusty country, lot of contact lenses related allergies, corneal ulcers, abrasions. So when you think of practical scenarios in Pakistan, I think contact lenses should not be used. AFK glasses should be used. But in quality conscious patients, quality conscious parents, and if they can afford, I think, and if they can comply with it, I think contact lenses are better. So again, it's a question, you cannot make it a rule of thumb. So it is the need that, is the better judge.
Thank you so much. It's time for our next debate. The question for our next debate is progressive addition lenses versus standard single vision lenses for myopia control. We have Dr. Shabana Chaudhary, who will be going for progressive addition lenses for myopia control.
I'm for the progressive, for the progressive addition lenses, and I will endorse Dr. Paul's perception that is ये जरूरी नहीं कि ये हमारे आपस वो है ये हमें दिया because it has been given to us that we have to talk about it. Yeah. So first of all, we need to understand the theories behind behind myopia. There are three common theories that the myopia progression occurs because of the defocus of blood, or there is a mechanical tension theory and accommodative lag theory. So myopia progression is faster in the age between 7 to 10 years. We all know that. So the goals for the myopia control depend primarily on the child's age, including the other factors like the usage of screens and other things. Myopic progression in children can be influenced by binocular vision, and especially in near esophagia and accommodative lag. These are the things that cause the progression of the myopia. So we have to tackle this one. And how can we do that? I'll give you the examples later. So there are many type of lenses. Child have to wear the lens, have to wear the glasses for a better visual outcome. So there are many different glasses, different lenses in the market, and we have to choose for them. Glasses are the visual aids that improve the vision as long as the prescription is appropriate and precise. So according to one of the study, the single vision lenses one power across the entire area, while in progressive addition lenses, there is different powers, and with the one glass, the child can see better at far, at intermediate distance, and at near. And the positive power in the bottom of the lens will allow the child to perform the near work, and it will relax the child, and there would be no accommodative fatigue. But not only the pathogenesis, the pathology behind the myopia we are concerned, we need to consider the cultural context. When we ask the parents that your child needs the glasses, they will just get upset, and most of the time they are in a denial phase. They refuse to, they would say, all of us listen to the sentences like, I don't want my child to wear the glasses. What are you saying, doctor? It's not in my family. So you are making my child a funny creature. So he can see me. So, and not only this one, but also the kids are very image conscious nowadays. If they need to give the glasses for the far and the near or the bifocals, they won't accept it. So the answer to them, to all the things is that we need some special glasses that not only answer parents, parents' concerns, and also as well as all the stakeholders, like the child's concern about the cosmesis. So, and also the single vision glasses are, in literature it is mentioned that these glasses don't slow the myopia, and the single vision glasses, they even worsen the myopia. So give Paul to the children, and there is a question that the additional lenses, these are very expensive, okay? But we all know that the estimated myopia epidemic is coming up. So there will be 50% of the people will be myopic by 2050. We don't want to make our children to be myopic. We need something that is comfortable, that is acceptable by all the stakeholders. And the answer is Paul. Thank you.
Thank you very much, Dr. Shabana. She's right. Myopia is the problem of the century, and we should have different ways to combat it, because not one treatment works. Dr. Ali Sadiq was supposed to go with single vision glasses, but unfortunately he's not available. So Dr. Shabana clearly wins this one. So we are a little short of time. I will proceed to our next debate. And the next debate is post-operative and myopia management in pediatric cataracts. patching alone versus pharmacological penalization. I would invite Dr. Ahmed Raza, who will go with patching alone.
Bismillahirrahmanirrahim. Post-operative amblyopia management is essential in children. Amblyopia refers to reduced vision in one eye or both eyes due to abnormal visual development. And amblyopia is common after unilateral or bilateral after cataract surgery. Early intervention and management is very crucial for maximum optical visual outcomes. After cataract, there are causes such as deprivation, amblyopia, refractive error, or due to strabismus, a misalignment of eyes. There are options regarding amblyopia management are patching and atropine penalization. There are advantages of patching. First of all, the duration and intensity of the patching can be customized or tailored. If there is reverse amblyopia, it can be stopped. And there are no pharmacological side effects due to systemic absorption of atropine or due to photosensitivity or photophobia. And in bilateral cases and in severe amblyopia, patching is more efficacious, more superior to atropine. There are limitations of atropine such as photophobia, blurring of vision, allergic reactions, and in severe cases and in bilateral disease, there are reduced effectiveness of atropine. There are scientific evidence and studies which shows that there is superior improvement in visual acuity and better compliance and long-term visual outcomes with patients treated with patching. There is a social stigma related to patching that can be controlled with parents counseling, ensuring consistent patch use, emotional support of child, and regular follow-ups to the doctor. Thank you.
I would like to invite Dr. Ajmal Chaudhary, who will go with pharmacological penalization for postoperative amblyopia.
I'm presenting my point of view against the patching. I'm nowadays working as associate professor in Sheikh Zayed Medical College, Rahim Khan. So pharmacological penalization, क्यों ना हम redefine करें अपनी amblyopia treatment को. पैचिंग तो हम स्टूडेंट थे उस वक्त से सुनते आ रहे हैं, एट्रोपिन पेनलाइजेशन के बारे में भी सुनते आ रहे हैं, लेकिन मोस्ट ऑफ द टाइम वी ऑल आर डूइंग द पैचिंग. मेरे फाजिल दोस्त ने पहले कुछ एम्ब्लियोपिया का बेसिक तो बता दिया है, तो उन्होंने जिक्र कर दिया लेजी आई है. ट्रेडिशनल ट्रीटमेंट्स जो हैं वो डेफिनेटली पैचिंग और एट्रोपिन पेनलाइजेशन ही हैं. But my stress would be that the pharmacological penalization is a better option than patching. And now we consider why this is more important. Atropine drops blur the vision in stronger eye, forcing the weaker eye to work harder. They can be used typically on weekends and as per other requirements as well. But patching involves covering the stronger eye for several hours daily and requires strict adherence and may cause discomfort. So my point of view is atropine penalization outshines patching in effectiveness, ease, and overall child well-being. Now consider a child who is wearing the patch. Imagine he is with a patch. वो बेचारा एक ही आंख से घूर रहा है, देख रहा है, और lot of questions from the parents, from the peers, from the school, and having a discomfort of adhesive tapes. And now imagine the use of atropine, just one drop in one eye and using the bad eye. Now what's the problem with the patching? Emotional और practical drawbacks अगर देखे जाएं, bullying and stigma due to visible patches. हर बंदा क्लास के अंदर बच्चे को बुली करता है और बच्चा और फील करता है, और चिल्ड्रन खुद रेजिस्टेंस शो करते हैं ड्यू टू दिस डिस्कम्फर्ट ऑफ पैचिंग. एंड कंप्लायंस रेट जो है वो लो है क्योंकि सक्सेस डिपेंड करती है एडहेरेंस टू द कंप्लायंस, और पैचिंग आमतौर पे बच्चे नहीं कर रहे होते और पेरेंट्स भी इनके साथ ऑन बोर्ड नहीं होते। क्लिनिकल कंसर्न देखा जाए तो रिस्क ओवर पैचिंग लीडिंग टू एम्ब्लॉपिया इन द स्ट्रेंगर आई। तो पैच करते करते जो गुड आई है उसको भी बाज गात ज्यादा पैच करते हुए उसका भी एम्ब्लॉपिया हो जाता है, ये भी एक ड्रॉबैक है पैचिंग का। एट्रोपिन टेम्पररीली ब्लर्स विजन इन द स्ट्रॉन्गर आई, कंपेलिंग अ वीकर आई टू वर्क हार्डर। अब ये एट्रोपिन जब डाली जाएगी, इट इज इनविजिबल, स्टिग्मा फ्री ट्रीटमेंट हमें ऑप्ट करना चाहिए। मिनिमल डिस्ट्रप्शन टू डेली लाइफ, और एट्रोपिन पेनलाइजेशन मिनिमाइज साइकोलॉजिकल स्ट्रेस, ये एक बहुत बड़ा बेनिफिट है। लेस रेजिस्टेंस फ्रॉम चिल्ड्रन एंड हायर कंप्लायंस। अब अगर रिसर्च और पब्लिकेशन की बात की जाए तो जो हमारा पीडियाट्रिक आई डिजीज इन्वेस्टिगेटिव ग्रुप जो एम्ब्लॉपिया ट्रीटमेंट ट्रायल में बताता है कि एट्रोपिन और पैचिंग के रिजल्ट सेम ही हैं, ये बहुत पहले उन्होंने स्टडी करने के बाद बता दिया है। और एक सिस्टमेटिक रिव्यू किया गया 2017 में, उसमें साइकोलॉजिकल इम्पैक्ट बताया गया इसका, इट हैज अ गुड कंप्लायंस विद एट्रोपिन एज कंपेयर टू द पैचिंग। सो फ्यू पॉइंट्स, पैचिंग क्यों इतनी अच्छी नहीं हो रही और पैरालाइजेशन क्यों अच्छी हो जाएगी। सो इफेक्टिवनेस दोनों में इक्वल है, आई एग्री। कंप्लायंस हाई है इसमें पैनलाइजेशन में, जबकि पैचिंग में लो है। सोशल स्टिग्मा पैनलाइजेशन में बिल्कुल नहीं है और इसके अंदर बहुत हाई है पैचिंग के अंदर। साइकोलॉजिकल डिस्कम्फर्ट हाई है पैनलाइजेशन के अंदर और वेरी लो है इन पैचिंग। और कॉस्ट की बात करें तो जस्ट 1 ड्रॉप ऑफ द एट्रोपिन, और पैचेस के लिए तो आपको कॉस्ट भी बियर करनी पड़ती है, काफी है। और बाज़ का तो कोई हमारे लोकल ब्रांड अवेलेबल नहीं है, फॉरेन ब्रांड बड़े कॉस्टली हैं। सो इट्स इजियर टू इम्प्लीमेंट, केयर गिवर फ्रेंडली है, जो अलाइड हेल्थ प्रोफेशनल हैं, ऑप्थेल्मोलॉजिस्ट हैं, उनके लिए इजी काम है प्रिस्क्राइब करना। नो डेली बैटल्स ऑन पैचिंग, घरों के अंदर लड़ाई हो रही होती है पेरेंट्स की भी और बच्चों की भी, और सारा ये इशू चल रहे होते हैं। चाइल्ड सेंटर है, बच्चा इमोशनली वेलबींग फील करता है और पीयर एक्सेप्ट करते हैं बच्चे को पेनलाइजेशन में, और क्लिनिकली प्रूवन है, हमने 2 स्टडीज इसकी आपको कोट की हैं। सो एक सिनेरियो है कि जिसमें 7 ईयर ओल्ड सारा, वो कहती है कि नो मोर टीजिंग एट स्कूल, जस्ट 1 ड्रॉप एंड आई एम डन। जो पेरेंट्स से पूछा गया, दे सेड दैट यूजिंग ड्रॉप्स मेड द प्रोसेस स्ट्रेस फ्री, my child fondly cooperates with the treatment. So why settle for visible and disruptive when we have invisible and effective treatment? Pharmacological penalization is the future of amblyopia treatment. And with this, I request all of you, let's advocate for the treatment that prioritize children's vision and happiness. With this, I close and thank you very much.
Thank you, Dr. Ajmal. I would like to take poll from the House. Those in favor of patching? That's a big number. Almost the whole of the House. And anyone in favor of pharmacological penalization? Okay. So our next debate is role of medical therapy in congenital glaucoma, temporary measure or long-term measurement. Yes, sir. Yes, sir, please.
The problem with atropine is that there are 2 main problems. Number 1 problem is that it is a drug. So it has local effects on eye and it has systemic effects on your body. And it is an autonomic drug, so it is acting everywhere. Number 1. The second problem is that the theme of patching or amblyopia treatment is that the amblyopic eye must have a better VN or a better VN chance than the other eye, whereas the other eye should have a poor VN. Many times when you are using atropine, the eye which is being atropinized still has a better VN than the eye to be penalized. So there is no question of atropine. So after atropine use, you must take the VN. So if the VN is better, go with it. If the VN is not better.
Thank you so much, sir. Yes, sir, please.
It's only that this actually topic was
mentioned wrongly, because it should have been mentioned that it is unilateral cataract surgery rather than the cataract surgery. So I think cataract surgery means bilateral, and
Not necessarily, sir. Not
I mean,
always.
but if you mentioned it that unilateral cataract, then it is patching and penalization both can be. Otherwise, if it is cataract surgery and if it is bilateral cataract surgery, there is no need for the amblyopia therapy of patching.
उसमें तो सर मतलब उसमें तो ये ना कि there is no need, the need does not arise, so we cannot debate on it.
Role of medical therapy in congenital glaucoma, temporary measure or long-term management. Medical therapy cannot replace surgery in the management of primary congenital glaucoma and is merely a temporary measure. So I would be going with the topical treatment or medical treatment is a temporary measure, not a long-term measure. Reason? Pathophysiology. Pathophysiology of primary congenital glaucoma is that it is a genetically determined abnormality in the trabecular meshwork and anterior chamber angle, leading to poor aqueous outflow. High ciliary muscle insertion into the trabecular meshwork, increased amounts of collagen in trabecular being coarse. So the problem is anatomical, and it has to be corrected with surgery. So I don't think that drops will work for a very long time. Poor visualization of the Islam canal and collector channels. Another reason is polypharmacy for primary congenital glaucoma, where pressure at presentation is 30 to 40 millimeters of mercury. You cannot expect one drug to work. You will have to add a second drug, then you will have to add a third drug. Then this will lead to poor compliance and polypharmacy. Also, it would be heavy on the pocket of the patient. Adverse effects. There will be ocular side effects like blepharitis, redness, trichomegaly, periocular pigmentation. Then there are systemic side effects with beta blockers. You can have bronchoconstriction and you cannot give it to asthmatic young patients. Then there is need for frequent follow-ups. You cannot expect your patient to go for 2 or 3 months on medical dropping. You have to call them back and monitor the pressure again and again and again. There is lack of cost effectiveness with medical management. There is insufficient intraocular pressure reduction. When the presenting intraocular pressure is 40 or beyond 40, the medical drops will only lower it by maximum 20% or 30%, which is still not acceptable and still not sufficient. So still, the medical treatment is a temporary treatment. There is difficult monitoring and need for EUA. When you call back the patient for follow-up, you want to monitor the intraocular pressure, you have to take several other parameters, and you cannot do it more frequently. There is a need for EUA, so you can carry out an EUA 3 monthly, 6 monthly, but you cannot do it every month. Then there are limitations, like brimonidine is an alpha-2 agonist, and it is absolutely contraindicated in children under 2 years. It is relatively contraindicated in children under 6 years. So there are limitations of medical treatment. There is a room for complications like globe enlargement, Hopps-Trier, myopia, astigmatism, strabismus, optic nerve compromise, and amblyopia if you are not sufficiently treating, lowering the intraocular pressure. Why wait when you have so many other options like goniotomy, trabeculotomy, trabeculectomy, combination of these procedures? We have valves and transtheral cyclophotocoagulation. So why let your patient stay on medical treatment alone? In short, I would like to say that medical treatment in primary congenital glaucoma is just like giving candy to a child who is throwing tantrum in a grocery store. You stop the crying, but you are not addressing the behavioral issues. Thank you. I would like to invite Dr. Zubaida Sirang. She will be advocating for medical treatment as a long-term management.
Thank you, Dr. Fiza. Again, disclaimer, I might not agree with the topic that I've been given, but but since I've been given the topics, so I'll give few arguments. Where we can give IOP lowering drops is compared to surgery in pediatric population in congenital glaucoma. So the collaborative initial glaucoma treatment study shows that in moderate to advanced glaucoma, surgery is always the best choice. But in milder form of glaucoma, we can give IOP lowering drops for quite some period. We might, ultimately need the surgery, but again, we can give the drops. So in certain situations like surgery is not feasible, for example, in children, if we cannot give general anesthesia, how can we do, any kind of surgery on them? So if surgery is not feasible or not possible, we can give IOP lowering drops. In the areas, for example, we talk about the far-flung regions of Pakistan where I have worked. Can we give, if there are no experts, we don't have pediatric ophthalmologists working there, can we do surgery on a pediatric population if they cannot be referred for financial constraints or for whatever reason? We can give IOP lowering drops because that is not an absolute no-no. We cannot give alpha against yes, but we can give other IOP lowering drops to at least lower the progression till we reach the ultimate solution. And then there are few other glaucomas. For example, if steroid-induced glaucoma or aphakic glaucoma, we can absolutely give IOP lowering drops. Thank you so much.
Thank you, Dr. Zubeda. Those in favor of medical treatment as temporary measure? That is almost everyone. Okay. Our next debate is intraocular lens power calculation in pediatric cataract. We have Dr. Ashal Pal, and he will be going with targeting emetropia versus allowing for myopic shift.
Bismillah Rahman Rahim. Thank you, Dr. Fiza. So my topic is that we have to make the patient emetrope on the table in the OT just after the surgery is finished. So the patient has to be made emetrope. So targeting emetropia in pediatric cataract surgery with IOL implantation. आप लोगों को टॉपिक की समझ आ गई ना कि हमने सर्जरी की और emetrope कर दिया पेशेंट को like adults. So my first point will be straightforward versus assumptive decisions. So as I am advocating that we have to make the patient emetrope on the table, so this decision of keeping the patient emetrope is straightforward as compared to the assumptive decision in which we have to make lot of calculations, and then we have to decide which number to put in and which number not to. So targeting emetropia is a straightforward and reliable decision based on measurable factors like keratometry readings and axial length. So the variables are only two. Planning for residual hypermetropia relies on assumptions requiring predictions about eye growth, future refractive shifts. These predictions are uncertain and vary from child to child. The assumptive approach risks creating uncontrolled myopia, with its magnitude being unpredictable. For a child's lifelong vision, a simple and reliable approach is always better than relying on guesswork or assumptions. The second point is simple decision versus complicated decision. The emetropic approach is not only straightforward but remarkably simple. It involves just two primary variables, K readings and axial length, to calculate the IOL power. This ensures a smooth and standardized process. Contrast this with the complexity of a residual hypermetropized approach. Here the calculation becomes a multifactorial challenge. Not only do we need to consider the basic biometrics, but also factors like child's age at the time of surgery, refractive status of the fellow eye, parental and familial refractive history, race and gender differences. These additional considerations demand expert knowledge, specialized tools, and advanced experience, a combination not always accessible, especially in regions like ours, Overcomplicating this process risks introducing errors, leaving children at a disadvantage. Third point is practical versus ideological decisions. Choosing emetropia is a practical and simple solution that can be managed by a general eye care team. In Pakistan, we all know that 90% of the pediatric cataract surgeries are done by general ophthalmologists. For general ophthalmologists, the decision has to be made simpler. So they can be managed by general eye care team. It ensures a timely and effective surgery for children. Managing hypermetropia is much harder because it requires a specialized pediatric eye care team, not just a surgeon. Involves complex surgeries and careful post-operative follow-up. In countries like Pakistan, specialized pediatric care is rare and hard for most people to access. We need realistic and practical healthcare solutions that serve more people, do not rely on scarce resources. The last point is myopia versus amblyopia. Myopia is manageable with modern options like photorefractive surgery, corrective glasses, contact lenses, and amblyopia caused by hypermetropia or poor correction is a much bigger challenge. So in one case you are dealing with myopia, in other you are dealing with amblyopia, hypermetropia leading to amblyopia. So it's hard to treat, especially if undiagnosed early. It significantly impacts vision during critical developmental years. Visual outcomes of emetropic decisions are far better. A child with refractive error like -8 diopter sphere can achieve 6.66 or 6.9 vision with correction. In contrast, residual hypermetropia with consequent amblyopia may leave them struggling with 660 vision or worse. Preventing amblyopia is far more important, even if it means managing strong myopia later. Take-home message: targeting emetropia solves the problem at its root. It solves the problem. It corrects IOL placement, optimizes the child's vision immediately. Any remaining refractive error can be managed with glasses. Whereas planning for residual hypermetropia creates a problem. It induces hypermetropia, leading to challenges in managing or preventing amblyopia, requires significant time and resources from families and healthcare teams. So let us choose clarity, simplicity, and practicality. For the sake of the child's vision and future, targeting emetropia is not just a better choice, it is the responsible one. Thank you.
I would invite Dr. Ahmed Raza, and he will be going with planning hypermetropia.
In pediatric cataract surgery, mainly the IOL power calculation is crucial. Okay. Pediatric cataract surgery differs from adult in this way that there is small size of eyes, constantly changing refractive errors, and tendency to develop amblyopia.
That's a light.
In pediatric age group, there are mainly eyes growing, and there is progressively increase in axial length, flattening of the cornea, and change in the power of lens. So there is, when eye is growing, then it is going toward myopic shift. So it is necessary to, it should be under corrected, and there is just a simple formula. If the patient's age is less than 2 years, then 20% reduction of original IOL power, and age is from 2 to 7 years, then 10% reduction of the intraocular lens power or biometry. Or rule of 7 or rule of 6 can be applied. Here the age and postoperative refractive error goal is 7. If the patient's age is 2 years, then refractive error plus 5 residual hypermetropia should be there. Its advantage is only that it accounts for future eye growth, because eye is growing, axial length will increase, and at the age of 7 years it will emetrope, eye will emetrope, and it reduces the risk of amblyopia, and it accounts for the future eye growth. And most of these studies support that better long-term refractive outcomes with planned myopic shift, and reduced rate of amblyopia, and better visual acuity at the time of maturity in patients who are going with residual hypermetropia and glasses. Thank you.
Let's take a quick poll. Those who would like to go with undercorrecting the IOL power at the time of implantation in congenital cataracts. Okay. And we know how many would go with completely emmetropizing the child. So, so let's take final expert opinion with the panel and then our worthy seniors. Let's start with Dr. Levine. What would you say?
I think we covered this yesterday. I would say that I would vote for hyperopia, that you have to then correct. And if you have a family that's able to do that, and a family that can afford to do the glasses that are going to be required over time, in the long run, that'll be better for the child. However, if in this environment it is hard to get glasses, hard to wear glasses, then making them emmetropic now, at least for several years, and then dealing with the problem down the line may make more sense. So it's going to be environment dependent.
Thank you, sir. So would you like to add anything to the IOL power calculation?
Yeah, I think it's, we normally do, we don't do an emmetropization on the first instance. We do calculate, and then we adjust, we give the adjusted power of the lens, and this is a normal practice. Everybody does it. So there's no question on that.
I would like to say something
Yes, sir.
now.
Please, sir.
Now I will
Please do.
speak truth. The truth is that this approach which Ahmed was advocating, that is a better approach, definitely, and I myself do this approach. But there are again certain exceptional cases. If you know that the family is coming from a very far-flung area and they are not going to use glasses, so in that critical period of development, myopia is a blessing, because a small child has a small world. So if the patient is myopic, like myopia of 4 or 5 diopter for 2 to 3 years of life, at least in that critical period, he's saved. So in those exceptional circumstances, we can use this strategy. And the purpose of this debate is actually, which I said in the early, basically we are here to present different school of thoughts and then decide accordingly. Every weapon, every strategy can be used in different circumstances. So it's the circumstances, part of the world where you are practicing ophthalmology, that are the determinants of your decision making. Thank you.
And just like Dr. Levine said, that every innovation should be supported with research. Thank you to the panel. I would like to ask Professor Mumtaz Saab for his expert opinion. What would you say, sir?
Better mic then. Mic.
Thank you very much for this honor. Ashal Khan Pal साहब, पहली बात तो ये है, let me go a little behind, कि हमें correction करनी चाहिए या नहीं करनी चाहिए. I would go in favor of correction. It's not the problem of children, it's the problem of the parents. They come to you with the complaints that मेरे बच्चे की strabismus develop हो रही, ये सीधा नहीं देखता, और जब इसके अलावा खाता नहीं पूरी तरह, इसकी नींद नहीं पूरी होती, वो जो बड़ा होता जाता है. These eyes are the windows to the brain to think. Whatever we are going to put through these windows to the brain, the person is going to respond, and it elevates the personality of the child with correction. नंबर 2, कॉन्टैक्ट लेंसेज के बारे में. अगर आपने कॉन्टैक्ट लेंसेज एडवाइज करने हैं, लगाने हैं, तो प्लीज़ एक मेहरबानी और करना कि लगाने वाली होती है सिर्फ माँ. बाप सिर्फ बढ़ के मारने जोगा होता है, वो मेरा बच्चा तो ये तो वो, लेकिन लगाना माँ ने है, उतारना माँ ने. आपने उसके नाखून ज़रूर काटने.
100%.
Very right, sir.
practical tip.
It is very important to counsel the mothers for hygiene.
अगर आप उसको कहेंगे ना कि नाखून काट ले, तो कहेगा मेरे बच्चे नु ऐनक ला दो, कॉन्टैक्ट लेंस.
Thank you,
She
sir.
would immediately say,
Strictly advised
no,
to trim
please
the
don't put
nails
the contact lenses,
if she has to put the lenses.
just spectacles. तो मेरे मतलब कहने का है, डॉक्टर साहब ने एक बात बड़ी की, हमारी लोकेलिटी और हमारी ग्लोबली ओरिएंटेशन कैसी है पीपल की. हमारे पीपल जो है, हमारे लोग जो हैं वो इतने अनपढ़ नहीं. अब भी 25 to 26% इज द लिटरेसी रेट, और इसमें आप क्या एक्सपेक्ट कर सकते हैं. सो बेहतर ये होगा कि आप ऐनक लगाएं. 10 दफ़ा भी बदलनी पड़ती है तो दैट इज़ वेरी इजी. और इसके अलावा माशाल्लाह ब्यूटीफुल डिबेट. डॉक्टर अशल खान पाल, थैंक यू वेरी मच. आई कंग्रेचुलेट यू.
Thank you, Professor Mumtaz. Over to Professor Salim Saab. Sir, please enlighten us.
Thank you very much. I think lot have been said and discussed very openly. And I am sure the things are much clearer to all of us. These were very important topics, and they have been rather very nicely debated, which is a good thing, positive thing. Question is practicality. In every topic we discussed, glaucoma management, we know it's medical treatment is no treatment. It's only a time-buying technique, if it can be. There are only very few patients with congenital glaucoma, pressure in their 20s, maybe early 30s, who will probably benefit from carbonic anhydrase inhibitors, topical or systemic. Putting timolol or something like that one hardly matters. It doesn't help. So they are actually waiting to be operated, and they should be operated as early as possible. Nothing should be left for the second attempt until and unless one have to do a second attempt, because time is not on your side. Hazy cornea is an interference, damaged disc is an interference, amblyopia is an interference, and getting really to the useful vision becomes a dream only. Question was how to, what should be the correction at the time of surgery. Well, both sides have their merits, but I would say that I always attempted during my days to get ametropic vision, make the eye ametropic with intraocular lens, though I failed many times for various reasons, astigmatism, other things. And it makes a difference if the child can see, because the vision development process does not go for the rest of life. There is a time. They say that the best visual development period is first 3 years of life. Then its speed decreases, and after the age of 6-7 years, that probably is the end point. After that, there is a very minimal chance that it will improve. So we'll have to make every endeavor that we provide the best possible chance for this child to develop vision, be it uniocular, be it binocular. Not easy job, but have to do. Make a good effort. I would congratulate at the end. You have done a very good job, and may God bless you. Thank you.
Thank you so much, sir. With this, we conclude our great debate session. Thank you so much for your patience and participation. Let's have a group photo. And we know that everybody is tired and it's late and everybody wants to go back home. Just a quick photo, and then that's it. Thank you very much.